This
I'm Susan
conference will
Robinson.
now be recorded.
As you heard there, the webinar is being recorded. I'm Susan Robinson Whelan, and I'm a researcher at Tier Memorial Hermann's Spinal Cord Injury and Disability Research Center, as well as Baylor College of Medicine's Center for Research on Women with Disabilities. So I work closely with both Dr. Heather Taylor and Dr. Margaret Pagnosic, who are the co-chairs of the ACRM's Spinal Cord Injury Women's Health Task Force. So today, in our usual meeting time, we are instead honored and very excited to have the opportunity to host a webinar here with Dr. Ann Berndl presenting for us. I would like to mention that the webinar is presented on behalf of ACRM's Spinal Cord Injury Interdisciplinary Special Interest Group. And as I mentioned, today's webinar will be presented by Dr. Ann Berndl. It's entitled Creation of the Spina bifida Women's Health Guidelines, Methods, and Future Projects. Before we get started, here also is information about how you can connect with ACRM. So we welcome you to do so. You may use this to help join the Women's Health Task Force, which we would welcome you to do, and also get additional information on the special interest group. And we also want to point out that ACRM's conference is coming up in the fall. It's a virtual conference, and we would encourage you to register, attend, and join us there. Before we get started, we have some housekeeping issues just to mention briefly. I do want to point out again that the meeting is being recorded, and we also would like to ask all attendees to keep your phones or mics muted and your cameras turned off throughout the presentation. We anticipate having about 15 to 20 minutes at the end for discussion following the webinar. So if you do have questions, please type them in the chat feature, and we will address and get to as many of those as we can in the later part of the hour. And with that, it is my pleasure to introduce our guest speaker, Dr. Ann Berndl. Dr. Berndl is a maternal fetal medicine specialist at SUNY Brook Hospital, where she's the director of Accessible Care Pregnancy Clinic. She's an associate professor at the University of Toronto and the chair of the Spina bifida Women's Health Guidelines. We very much appreciate your being here today, Dr. Berndl. We look forward to your talk, and we will now go ahead and turn the presentation over to you. Thank you.
Great. Thank you so much. It really is an honor to speak to you about the creation of the Women's Spina bifida Guidelines, and also maybe some things that, hopefully we could even collaborate on in the future in terms of other guidelines. If we could advance to the next slide, please. So in terms of objectives for this presentation, I do want to discuss a little bit about why we need guidelines. Guidelines are an important part of knowledge translation and clinical care, and so it's something that is near and dear to my heart. And also, I would like to highlight what are some of the key aspects that we discovered during the development of the Women's Health Guidelines for Spina bifida. And then I want to go through the process and then see what we might be able to do in the future. Next slide, please. I do have conflicts of interest to declare. I do have a few research grants that are important to mention. One is a grant from the Ontario Neurotrauma Foundation for the Spinal Cord Injury and Neurogenital Health Project. And we also have some funding from Hydrocephalus Canada for a summer student looking at reproductive health and sexual health pregnancy experiences for women with spina bifida. Next slide, please. So why do we need guidelines? So we know, and I'm sure the people who are attending this webinar today know that more women with physical disabilities are choosing pregnancy. And we also know that women with physical disabilities are more likely to have pregnancy complications. So some of those complications are preterm birth, preeclampsia, or some people call it toxemia, where people have high blood pressure and changes in the metabolism of their body. Also, babies do have some sequelae, such as being born with low weights. Sorry about that. So Another reason, why do we need guidelines? Healthcare providers, we know from the research, may not be trained in the care of women with physical disabilities, specifically surrounding pregnancy and sexual health. We know from the research as well that there's a lack of confidence in caring for women with physical disabilities. And we want to improve a standardized approach to this so that women with physical disabilities who may not, for example, be near a clinic that can care for them specifically, there are clinicians that might feel more confident in providing that care. Next slide, please. So when we created the guidelines for the care of people with spina bifida, we really needed to recognize, while we were endeavoring towards this, that a lot of these outcomes don't have good research behind it, meaning we don't have randomized control trials available. The prospective or retrospective data we have is small. And so part of what we needed to do was identify what we had, but also look for what gaps we had in the research, and then we could use it to look for priorities for the future. And then by going through all of that research, it helps to identify what we should be doing, where can we be putting funding, and how can we work together to improve the knowledge that we're noticing is lacking. Next slide, please. So the authors on this particular guideline were myself, Dr. Nosek, who I believe is here today, and Dr. Ashley Waddington, who is a OB-GYN at Queen's University. This was a very large guideline. It took quite a bit of work to put together. And it was broken down by age group because of the large spread that it looked at in terms of the number of topics we were trying to cover. So we had to look at infants, we were looking at what happened to young girls, and then we wanted to look at gynecological health as well as antenatal health, labor and delivery health, breastfeeding health, and menopause for women with spina bifida. Next slide, please. I do want to go through some of the highlights that we discovered when we did this, but I also want to make note that this was just one small piece of a very large guideline project that had many subgroups within it, and this was particularly the Women's Health Guideline. So when I go through this, I think that some of you may be familiar with some of this clinical aspects of management of women with spina bifida, but these were some of the things that we found that we felt would be really some key driving points. Also, I want to make note that when we're writing guidelines, we're trying to give action words for people so that they actually know what to do when they're presented with an individual with spina bifida, or for whatever reason that we're doing the guideline, to help that person know what to do in that clinical scenario. So one of the big things that we want to talk about is that preconceptual consultation is a key component of managing a high-risk pregnancy. And if you look across the board for all different reasons that someone might have preconceptual consultation, outcomes for women and babies are better than if someone is pregnant when they have a pre-existing medical condition without that preconceptual consultation. So knowledge is power for that woman, for her to know what to expect, and maybe if there's anything that she needs to do or learn about or have any studies done before becoming pregnant to improve her outcomes. So that might be first with her obstetrician, but that person might also benefit from meeting with her neurosurgeon or her neurologist, her physiatrist, or anyone else who is involved in her healthcare to make sure that she's really maximizing her health prior to pregnancy. Next slide, please. Another big thing that we found is it does appear that women with spina bifida do have a higher risk of preterm birth. This is important for that woman to know in terms of specific risks that she may have going into that pregnancy, and also so that we can monitor and manage that going in. Women who have spina bifida, depending on the location of the lesion, may also have changes in their sensory abilities and their ability to know if they're going into labor. And so knowing that you may have different sensations surrounding labor than someone who does not have spina bifida can help that woman be prepared to, for example, palpate for contractions of the uterus and paying attention to changes in her discharge. And that might be really important signs of preterm labor. Next slide, please. Here's some more of those action words that are there. So now we're thinking more about some of the physical changes that the woman might be experiencing during pregnancy. So as clinicians, we should be asking about symptoms of shortness of breath at each antenatal visit. And this is for two different reasons. So a woman who has spina bifida may also have scoliosis, and she may have a change in her lung capacity during pregnancy that needs to be addressed. But there also is a chance, especially if she uses a wheelchair or has limited mobility, that she's at higher risk of having a blood clot. And so we need to assess for that as well. So the asking about respiratory symptoms is really key. Other physical changes that the woman might be experiencing might be in her mobility itself. I see in the clinic that I run, and we also know from data that a lot of women who have reduced mobility outside of pregnancy have a change in the level of their mobility during the pregnancy as well, and need to change what different aids they use for safe mobility. So some women who, for example, was using crutches before may find that she needs a wheelchair, especially as she gets towards the end of pregnancy. Also using an interdisciplinary model, so referring to occupational therapy or physiotherapy might be really beneficial for some people. And that's not just for managing her own, for example, changes in mobility, changes in pain she might be experiencing, but also can make some plans for baby care afterwards. Next slide, please. Another key thing for women with spina bifida is to review signs and symptoms of shunt malfunction at each visit. So signs and symptoms of shunt malfunction look a lot like preeclampsia. And so a woman might start to have some neurological symptoms, headaches, visual changes, vomiting, and that looks a lot like preeclampsia as well. So it's important that she's aware that there are these changes that might happen, but also that her clinicians are aware so she can be worked up appropriately for both of these. Next slide, please. Bladder health, kidney health is really important for women with spina bifida, and making sure that we're tracking if there's any bladder infections that are there, that we're seeing them right away and we're treating them. Bladder infections are challenging in pregnancy because pregnancy itself predisposes to urinary tract infections, and women with spina bifida already tend to be predisposed to urinary tract infections. Urinary tract infections can go on to cause kidney infections. Kidney infections can increase the risk of preterm birth and increase the risk of preeclampsia. So it's really important from thinking from both a maternal health perspective, but also from a pregnancy health perspective, to pay attention to what's going on with the bladder and the kidneys. If someone is not able to catheterize anymore, sometimes you need to even refer to a urologist. Some women find that they're just not physically able to catheterize anymore as their belly grows, and if they're doing ins and outs, they can't do it any longer and need to use an indwelling catheter. Or if you're having troubles with that, a urologist consultation is really the right way to go. People who have underlying renal disease prior to pregnancy, so some women with spina bifida do have underlying renal disease because of chronic kidney infections in the past, are at increased risk of having small babies, they're at increased risk of having preeclampsia, and they're increased risk of preterm birth. So sometimes we need to make sure we have a nephrologist involved as well as the high-risk obstetrician in terms of managing all of the symptoms that are there. Next slide, please. When we're thinking about birth, having spina bifida does not mean you need to have a cesarean section. Women with spina bifida can have epidural analgesia, and they can have a vaginal birth. However, there are some things to consider when trying to select who is a good candidate for what type of birth. If someone has a shunt, we do try to decrease the amount of Valsalva that someone is doing, and so sometimes using forceps or vacuum to facilitate that second stage of labor or shorten the amount of pushing is necessary. For women who have a lesion above T6, they are at risk of autonomic dysreflexia in labor. It can also be triggered by vaginal exams. It can be triggered by catheterization. And so it's important to look out for that because that can be a life-threatening condition for some women. But also, again, it looks like preeclampsia. So you again have that clinical overlap. And it's important for people to be aware of this clinical overlap and evaluate for both. When you're making the decision between planning for a cesarean birth or a trial of vaginal birth, often an interdisciplinary team is a good way to go. Some women have had bladder reconstructions, that there's a concern about vaginal delivery causing trauma to it. Sometimes, we don't want to be doing a cesarean section because we know that there's a lot of scar tissue from a previous bladder reconstruction, and then you need to make the choice between a planned scenario with a urologist as backup versus the possibility of an emergency C-section where there may be more trauma in that situation. So sometimes it can be difficult, but the multidisciplinary team is really beneficial in those scenarios. From a postpartum perspective, we do want to encourage mothers who want to breastfeed to do so. And although we don't have a lot of data in this scenario, we want to make sure that women who do choose to breastfeed are supported by a lactation consultant when it's feasible. Next slide, please. All right. One of the big things, again, that comes up from doing a huge review like this, and again, those were just some little highlights that we found in terms of management, is that we get to see what gaps are there. And things that may be really clinically important become really evident that we don't have information, and it can be very helpful for directing future research. So, for example, there's no information available on the effect of pregnancy on continence. And this is a major question for women with spina bifida because continence is so closely linked with quality of life. And if there's going to be an impact on continence, that could be an important thing for women to consider when choosing if they're going to become pregnant. As well, there's no literature specifically on breastfeeding in the context of spina bifida. We know that women with physical disabilities are less likely to breastfeed their babies, and that's probably very multifactorial in terms of the reasoning for that. But in terms of this specific, in terms of spina bifida, we just don't know. So it's hard to give specific advice. We need to know more about why do women with spina bifida have preterm births? Why is there that increased risk? We think that there's likely a link to the increased risk of bladder infections and of renal dysfunction. We think that may be the driving force, but we really don't know if there's something else that's going on that's there. We also don't know a lot about other really important pregnancy outcomes, so things that an obstetrician like myself really cares about, so things like gestational diabetes and preeclampsia, malpresentation, meaning the baby not being head down. We do see that women with spinal cord injuries are more likely to have breech babies than head down babies, and we don't know if that's also happening in women with spina bifida. And then other postpartum complications, so what happens afterwards when they go home, are they more likely to come back to hospital, or what sort of challenges might a woman with spina bifida have after delivery? We also were looking, because the guideline was really quite encompassing of different age groups. Some key things that we found out, that there's not a lot of information on maximizing the physical sexual functioning of women with spina bifida. And we didn't know a lot about the management of menopause symptoms in women with spina bifida. So by doing this big review, and although we did learn, we really also exposed some fairly significant research gaps in caring for women with spina bifida during pregnancy. Next slide, please. So now I want to talk a little bit about the methods, because I'm hoping that maybe at the end of this there might be people who want to do guidelines together, or maybe we can find some projects that we can work on together. So a key part of this is that guidelines need to be transparent and systematic. So we need to have a process that we can follow, that then could be repeated by someone else who followed the same process. So I've just put up there, you can see on the slide, the publication actually of the process that was undertaken while doing the spina bifida guidelines. And this was the process that was followed for the huge overarching guidelines, where it looked at many different aspects of people's health, not just the women's health component. In the end, we want results that can be used by patients, families, and care providers. So it has to be very practical. It has to be something that you can describe a question and an answer. Because we know that we're going to have a lack of data in these areas, we also have to be able to make use of expert opinion, and we can do that following debate and consensus building. And ideally, you want to use international and multidisciplinary groups to get a really broad spectrum and a broad scope of what's going on. And next slide, please. So step one. So this is the practical parts of how to make a guideline. So one, we want to find some professionals and experts in the area, and you can use chain referral sampling. So that means, I know that, I have a friend who also specializes in this because I met them at a conference and they might be interested. So I call them up and say, hey, would you also be interested in being part of this guideline? So you might find someone that you find in the literature, but some of it is also just, especially when you're looking at really niche populations, people tend to find each other and who has a similar research interest. So you can find each other to help create that group. Then for this particular guideline, we were divided into multidisciplinary working groups. And so that's how we separated out into, for example, the women's health guideline, but there was also an endocrine guideline and a men's health guideline, so that we were all within the group that we were going to be participating in. Next slide, please. So the next step was to create guideline topics. So this is sort of trying to put together all of the different things that we would like to talk about in a guideline and trying to organize it in a way that would make sense. So in the women's health guideline, as I stated before, it was actually fairly large in terms of the amount of coverage that was there. But there's a lot of other pieces of women's health that are important to talk about, specifically surrounding, for example, prenatal counseling for a woman who was pregnant with a baby who had spina bifida. Sexual health and education and puberty were also found to be really important parts of to discuss. So the women's health guideline was broken off as one group, and then prenatal counseling, sexual health and education, and puberty were also then separate guidelines. So if we were going to build something, we need to really narrow in and decide what are we going to be talking about, and sometimes you have to make more than one. Next slide, please. The next step was to decide on primary, secondary, and tertiary outcomes. So these are things that we're hoping we can achieve with the guideline. So what are our major goals? So when we did the spina bifida guideline, the first one was we wanted accurate information for women with spina bifida about the impact of spina bifida on pregnancy and the impact of pregnancy on spina bifida. Then we also, as a secondary goal, was we wanted to help women with spina bifida maximize their sexual functioning. And then as a tertiary goal, we wanted to understand menopausal management options for women with spina bifida. Next slide, please. And then within each outcome, we need to ask specific clinical questions. I wonder, what should I do in this situation? Or this is a really important thing that people want to know about. So this is just an example. For example, in the pregnancy subcategory, some of the questions were, how should respiratory function be monitored during pregnancy? How do changes in mobility during pregnancy, how should they be managed? What should we be thinking about for birth for a woman with spina bifida? So it was a huge list of different things that we might want to ask, or that we think other clinicians or women with spina bifida or their families would want to know about. Next slide, please. So then we had a panel and ranking. And so that means that we had people with lived experience look over all the clinical questions that we were asking. So these were women with spina bifida, mothers with spina bifida, who looked through all these questions and then said, these are questions that are more important, and ranked them. And these are questions that are less important. And some questions that were just less important, we didn't need to include in the guidelines, or that, no, that's not really something that we need to talk about, or, this doesn't really make a lot of sense. So we can get rid of some of those. But also the benefit of this is that panelists were then able to also add other questions that the working group had not come up with. And so we could really make sure that we're having person-focused outcomes. Next slide, please. Then we did a big literature review. You need an experienced librarian to do this properly. And then you pull all your titles and abstracts, look through your inclusion criteria, and then create a big summary chart at the end. If you knew of some other papers, you could, of course, pull those as well and put them into the document. Next slide, please. And then you actually have to just sit down and write the guidelines. So you start writing out how you would describe things. You try to use the directive language, so an action word to put in front of each guideline statement. And then the group continues to circulate the drafts until you feel that it's complete. So everyone edits and changes and makes sure that it really is saying what you want it to say. In this particular guideline, we didn't use the grading of evidence, but in another guideline that I wrote about labor and delivery in women with physical disabilities, we used this, and I do actually like this grading method. And so you have two components of it. One is the strength of the recommendation, and then also the quality of the evidence. And so you need to put both of these aspects into your recommendation, and that helps people to understand essentially how they should weigh it when they're looking at their own practice. Next slide, please. So now that we know that we can do this with spina bifida in pregnancy or spina bifida in women's health, and it's been successful in that we've been able to create this guideline, how can we adapt that system to make guidelines for women's health for other types of physical disability? And this is something that I think is really important, because when you're looking at the literature right now, especially when looking for practical management aspects, things when you're really trying to provide care for a woman with a physical disability during pregnancy, all types of disabilities sort of lumped together into one group, and they say, and these are the outcomes, and this is what's happening, and that doesn't really help the individual very much. So I think that, ideally it would be great if we could have guidelines either for women's health or for pregnancy that's more topic specific. So for example, for spinal cord injury, but it also might be great, for example, for women's cerebral palsy or myasthenia gravis, skeletal dysplasia. So there's a lot of different groups that really would need different types of care during pregnancy, and they would have different things to think about during their pregnancy management. So if we could decide on a topic, what are we going to think about, what are we going to talk about, then we build our team. Next slide, please. And then we would have to decide on a scope. Would we want to do something on all of women's health, which is a very, very broad topic and would likely need to be broken down into many smaller ones, or some specific aspects of women's health, or focus on pregnancy, my favorite topic. So that's where my focus always tends to go. And then we would choose our outcomes and our specific clinical questions, as was demonstrated earlier. And then we need to think about a knowledge translation strategy. So that would mean, would we be affiliating with a particular journal, or would we be just putting them out? How would we help to put these out so that other clinicians and other women would be able to read it and apply that into their lives? Next slide, please. So this was just an example of some ideas for if we were going to do a guideline for women with spinal cord injury and pregnancy. So some of the outcomes, and again, these were just examples and of what this sort of putting this together might look like. So if we had a primary outcome about understanding the impact of spinal cord injury on pregnancy outcomes, secondary to understand the impact of pregnancy has on the health of people with spinal cord injury, and then tertiary to understand challenges people with spinal cord injury may have in the postpartum period. So that might be some important goals that we want, and then break that down into smaller clinical questions. So I put some examples like, what is the incidence of preterm birth and what increases the risk of preterm birth in women with spinal cord injury? If we're looking in the secondary outcome, how does pregnancy impact bladder management in women with spinal cord injury? And for tertiary outcomes, it might be, what challenges might people with spinal cord injury have to infant feeding, and how could those be addressed? So this is just an example of what that might look like. Next slide, please. So any questions? I'm happy to go through the guidelines themselves, or the process, or what sort of future projects we might be able to do together. Thanks so much.
It's Tara here, and great presentation. I think you have given us such a great view. I don't know how many months, years you have spent doing this work and bringing the teams together. Can you explain a little bit how the team got together, and as you suggested that if we are interested, we can do in other health conditions as well. So how did you get team, budgets, and timelines for this project? That would be very helpful for us.
So that's a great question. So again, I was just part of one of the small working groups. So I wasn't the chair of the overarching. So my exposure was as being part of the women's working group. And I was told about this from a colleague of mine who's a neonatologist. at Sunnybrook as well, and she knew that my clinical interests were on women with physical disabilities and pregnancy, and that was what my the patients that I see. And she was a member of the prenatal counseling group. So how do we talk to women who are going to have babies with spina bifida? And she said they're looking for people who can do this. And you know, would you be interested? And that's how she got me involved in it. So again, that's sort of that like chain recruitment where you know a colleague who also has an interest, and you start to put a group together. From a funding perspective, to be honest, I don't know how, you know, if there was any funding involved. I'm sure there was, at least to pay for the for some of the meetings, for meeting space, or for the research librarians' time when they're pulling the all of the articles. But the people who worked on it together were doing it as an academic pursuit. And the timeline was about 2.5 years.
Dr. Berndle, this is Peg.
Hello?
Peg.
Oh, hi.
Hi, this is Peg Gosek. I would like to know if you would recommend lumping together all the neuromuscular disorders and asking these questions as opposed to looking at one particular.
I'm sorry.
One particular neuromuscular disorder, like myasthenia gravis.
So, sorry, just to make sure I understand the question, you're wondering if we should lump like all neuromuscular disorders together as one into one guideline? Is that correct?
Yes.
I mean, I think at some point you sort of have to decide how specific you want to make each each guideline. I mean, myasthenia gravis is a really unique one because of the impact on the neonate. That is different from some of the other neuromuscular disorders in that the neonatal myasthenia gravis is really something we need to watch out for. And so that has a different type of management than some of the others. But, you know, if we have groups that are, if the data that we have in the populations are really very tiny, then sometimes it might make sense to put some of them together. And some of them might be similar enough to group together. So I think that would be part of, you know, if we were going to have an endeavor, you know, part of the literature review when we start asking the questions would also probably help us to see, you know, along what lines are appropriate to split things so that we still have information that's relevant on a more individual basis, but that we're also not just repeating ourselves a lot.
Thank you, Dr. Berndle. Does anyone have any other questions? You can either chime in and ask them as Peg and Tara have done, or you can use the chat function if you prefer.
One more question. What are your thoughts about examining these questions for women with cerebral palsy? I mean, there really is no literature about that. Can you share your thoughts on that, please?
Yeah, I think that would be also a really excellent guideline for a couple of reasons. One, cerebral palsy is common. You know, when you're looking at causes of physical disability, cerebral palsy is one of the more common causes. Also, I think we're going to have more women with cerebral palsy, and that, you know, part of, you know, obstetrics from my end that I see is we have more and more babies that are being born prematurely, and we know one of the sequelae of preterm birth and those babies are surviving as cerebral palsy, and these women are going to grow up and want families and want to know how to do that in a healthy way. Cerebral palsy is also interesting because there's such a spectrum in terms of the way it can impact an individual. So many different systems or the way that it might impact someone's mobility. So it is a very large spectrum that's there. So I think it would actually be a really good one to look at. And I've been looking at data to try to find some information about cerebral palsy. Again, there's not an awful lot out there, as you are aware as well. We're right now trying to do a large survey looking at pregnancy outcomes for women with cerebral palsy. It's actually been running for about 18 months, but we've had challenges with having women who have had a pregnancy completed. So it has been completed by a number of individuals, but to have women who have actually had a pregnancy, I think our numbers are quite low. It's something like we've had maybe 40 people of that demographic complete it, whereas most of the other women can comment on their sexual health care that they've had, but not a lot about the pregnancy component. But I think cerebral palsy is an important one to look at.
And another question will be, did you develop some kind of logarithms how to manage these patients? If somebody wants to go, and how do you manage that? If this happens, you do this. This happens, is do like treatment protocols, or you can say infographic one pagers, but which will be helpful to disseminate at maybe primary clinic levels and other gynecologists who don't see these patients very often.
Mm-hmm. So there's two things that are there. So one is, and I'm hoping this will be published in the next year. It's right now in committee with the Society of Obstetricians and Gynecologists of Canada. We have a labor, birth, and postpartum care for women with physical disabilities guideline. So that's a little bit more general because it has multiple causes of physical disability are addressed within that guideline. But it's just for the labor, delivery, and postpartum timeframe. And the other is a care pathway that I developed with Liz Young, who is the advanced practice nurse that I work with. And this was developed in conjunction with a multidisciplinary group that I work with, the people that I tend to refer my patients to, for example, the hematologist I work with, the neurologist I work with. We put together this package of what we would want to do at each gestational age. So for example, at 12 weeks, what are things we want to talk about and make sure we've addressed? At 16 weeks, what do we want to make sure we've done? When should we be doing pulmonary function testing and what individuals? It was this sort of pathway. And then we took this pathway to a team meeting where we had members of the community come and participate and also provide us some feedback about that pathway of care. And now we have a document that we use in the clinic to just make sure that we're on track because some women do require multiple consultations, and we're just trying to manage, they might have 5 different doctors that are seeing them during the pregnancy, and we want to make sure that we're following up appropriately with them. So that pathway of care, I think it would probably be an interesting one to publish, just so that other people have access to it. The hard part about it is I don't think I can say it's evidence-based. A lot of this is what we're happening to do because it's working for us, and we're doing a lot of learning along the way. Because this is a fairly, this is a new endeavor, and we don't know of any other clinics that are providing this type of care specifically right now. So, it's working, but I think it's something that it would be, right now it's hard to say how evidence-based it is or what we could compare it to. It's just what we're doing right now based on our best information at this point and expert opinion.
Thank you, Dr. Berndle. Any other questions? This is Susan Robinson Whelan. I was wondering, it sounds like a lot of the guidelines really are geared toward practitioners. I know you clearly involved women with spina bifida and families, and all other stakeholders in your earlier step of developing the focus and what you're going to look at and focus on for outcomes. Have you done much in terms of translation for that audience?
Not yet. So with the SOGC guidelines, so the guidelines for labor, birth, and postpartum care, because that's right now still just it's being edited and reviewed at this point in time. Hopefully it'll come out in the next year. And then after that, I'm hoping that, we do usually have some presentations at our general meetings, but I'm hoping to partner with some of the local groups, for example, the Center of Independent Living that we have here, to talk about them, so that all stakeholders, not just the clinicians, but the families, have access to that information as well.
So this brings me to the question that can this group be a site for dissemination? Can we disseminate some of these things which are expert opinions based on, but they are not published literature, and we know that there is, we don't have enough to go, and maybe if we want to publish something, we'll have something in 5 years. So something what like Anne has developed and many other people in this group might have developed. Can we be one of this women's group be a site for dissemination of some products as well, or a hub for that?
Is that a question for myself, or is it for?
It's the question for this group. So I would say it is for Dr. Margaret Mozak, who co-chairs this, as well Heather, and I think as you're here, Susan, even for the whole group to see that what can we do as a group to move some of these products forward. So for a discussion for the group.
And I know, Peg, are you still on? Did you want to chime in on that one? Yes, I see you there.
Yes, I'm here. I think we could easily use our own networks for dissemination. I think this is so valuable, even beyond spina bifida, to read these and know the categories of inquiry. Now, about disseminating it further through ACRM, I'm not quite sure how that would work. I wish we could. Now, Anne, you have an actual document.
I'm so sorry?
With the guidelines. Are you preparing it for publication?
The SOGC guidelines?
Yes.
Yeah, they'll be published in the JOGC.
And I'm sorry, can you repeat that? The JOGC?
JOGC, that's the Journal of Obstetrics and Gynecology Canada.
Thank you. And I think Peg was also asking, in addition to publication, do you have the guidelines produced in a format that can be easily disseminated or shared?
I have them. I think I need to just wait for my final review before disseminating them, but it's completed. I'll follow up and find out where they're at in their review process.
And also, can you give us the reference for the article that you showed on your slide?
Sorry, the article?
There was one article in your slides.
Oh, that was the methodologies paper. It was not written by myself. It was Timothy Bry, who really was the author of the overall spina bifida health through the ages guidelines, and that was the methodology paper of how it was completed. So I'm happy to look back and write down the actual reference and send it along.
Yes,
probably if you look really closely, you can see it, but it's probably a little fuzzy.
Yes. So I think we might be able to put together a brief report that summarizes the process and the guidelines and disseminated through ACRM.
I think it would be, if there is interest in forming a working group, to look at either specifically women's health or to look at pregnancy or to break it down into different groups. I think that would be really very interesting.
Also, we can include it on the Crowd website. Rosemary, can you speak a little bit about work you've been doing on our info guide?
Yes, I can. Yeah, we have been creating a series of info guides on pelvic, sexual, and reproductive health of women with physical disabilities. And we are going to publish those, put those on our website. And I think that's what you're talking about, Peg, that we are focusing on reproductive health and sexual health and all other kinds of, like I just said, topics related to women, the health of women with physical disabilities.
And we can include this brief report as a resource.
Right, that would be possible. Yes, that'd be great.
That would be terrific. This is Susan Robinson Whelan again. I appreciate your presentation today, Dr. Berndle, and the clarity with which you go through not just the guidelines and your recommendations along the way, but also the method that you used. And I can tell you've learned from the process yourself to kind of present very clearly with action words and really kind of step by step. So I really appreciate that. And I think that this slide deck and the webinar itself will be a great resource for people who are interested in following your model and trying to do similar work with additional topics or populations. I really appreciate the step 1, step 2, step 3. So thank you very much for that. I see we have still a few minutes left. Does anyone else have any additional questions?
It's Tara here, so I'm not hearing anybody else. I can take 2 minutes. How can we keep the interest of this group going? So it's a lot of effort for a person like Anne to come and present to us, and we do not have people in this group. I think there are 40 people, and we are not more than 10 people today. So I'll really see what really the membership wants to do, what interests them, and how can we keep them engaged. So in last few meetings, we have been very, very few people. So I'm just looking forward for some feedback and some directions so that we can increase people attending these meetings.
Yes, I agree. I think that will be well worth spending some time maybe exploring offline and in addition to discussing maybe in our next meeting. Does anyone else have any other questions for Dr. Berndle while we have her here sharing this information in the webinar?
Hi, I just have one quick question. I work with some adolescents and early adults with spina bifida who are there updated guidelines on bladder management for them, for these women by developmental age? I run into a lot of barriers with parents and urologists who are just letting their bladders do whatever they want, and by the time they want to go to college and participate in sports, they're like, I don't want to be wet all the time. And then they find me and I'm trying to backpedal and so I just want to make sure I am directing the physicians and the parents to the most updated clinical practice guidelines for bladder management for the young women.
So it's not my own area of expertise by any standard, but through the Spina Bifida Association, the Women's Health Guidelines, there is a bladder health guideline that I did not participate in, but is done in a similar fashion in that it's through the ages. So starting with infants, moving through childhood, adolescence, into adulthood, and so there should be an area within. If you just Google, Spina Bifida Association guidelines, they do have the entire PDF with all of the different topics that are covered within it, and there is a bladder health section that's there. So okay, I wish I would be able to help you, but just in terms of, I know that that's a guideline that was created.
Okay, thank you.
For sure.
That's wonderful, and that's great to know. Do you know if the project is largely complete across all working groups? Are those going to be are those already available across topics and outcomes?
So if you go on the Spina bifida Association website, they do have everything there already available. Right now, we are trying to have them published so that they're all have gone through a peer review process as well. So they've gone through the working group process and have been published on their website, but we want to also now have them peer reviewed as well. So those ones will probably be coming out over the next 2 years in journal format. But we were instructed when we created the ones that we submitted for journal format not to change any of the literature search or any of the guidelines from when we stopped doing that research. So it's about 2 years old, and then we'll have to redo it all over again, which is what you have to do with guidelines as more data comes out. So you can read them; they'll all be there. They're just not in journals yet. They're in on the Spina bifida Association website.
That is wonderful to know. Thank you so much for sharing that. And yes, I did notice as you were going through your step 1, step 2, step 3, that literature review was like one bullet.
But
And I think as we all
like
know
2
and
years to do,
appreciate,
but
that deserves far more than a bullet.
yeah.
Absolutely. Such wonderful work that you've undertaken, such so important, and to be honest, quite a bit of a lot of hard, dedicated work. So I really appreciate all of your efforts, and I'm looking forward to not just looking at your guidelines, but those of the other working groups. So again, thank you so much. That's wonderful.
Oh, it's my pleasure. It's my pleasure. And thank you so much for inviting me to speak to you today.
Thank you. We really appreciate it. Alrighty, so